Welcome to the Canon Medical Academy. Our purpose is to provide education and training that supports healthcare professionals with their continuous development, ensuring they are well equipped and kept up to date with the knowledge and skills necessary to thrive and to be able to provide the best possible care for their patients. An impressive, custom-designed, new facility that features multiple training rooms. Each room is equipped with a full range of clinical solutions. To fulfill this mission, the Canon Medical Academy is a hub for all your educational and training needs. It offers a holistic range of resources such as congresses, workshops, hands-on training, webinars, and a wealth of online materials. This extensive setup covers a wide range of clinical pillars, ensuring that every aspect of imaging in the patient pathway is optimized. Transforming knowledge into expertise, and expertise into advanced patient care. At Canon Medical Academy, every step is made for life.
I'm thrilled to be able to welcome you all today to this first of two in a webinar series where we are going to be focusing today on reducing disparities in women's health. We're going to focus today on the health gap and healthcare strategies for lifelong or life cycle well-being and health. We all want to thank Canon Medical Systems for organizing these webinars and for deciding to devote so much attention to this topic specifically and overall to the issue of the health of women in our world. And a particular thank you to Marta Satake for organizing the webinar and for bringing this wide-ranging group together that you'll see both today and tomorrow. I'm only going to briefly introduce the panelists today because their full bios have been shared with you and they're also available on the event website. But first we have Professor Amanda Henry, who is the program head for women's health of the George Institute for Global Health. Then we have Doctora Carolina Safalon Ferreira of the Hospital Materno Infantil Dr. Joaquim Sampaio from Brazil. And unfortunately today, we will not have with us Dr. Matthew Leonardi of the Advanced Gynecological, who's a surgeon and sonologist based at the Hamilton Health Sciences because of an unfortunate delay in his travel programming. But he has shared material with us and we will be able to speak to that throughout the day. Now, with that, I wanted to share just a few slides that will bring us some context to some of what we'll be discussing in our panel. And so I believe we're sharing the first slide now. Wonderful. And I'm going to just try to make the screen go large. As long as you all can see the screen, I'll just focus on, it's the same slides, but I can see on my own large screen over to the right. So first, you wanted to just say a few words about shifting trends in female mortality around the world and progress, gaps, and a little bit about misconceptions. First, in a world where we continue to see so much suffering and so much loss for a variety of different reasons, there is some very good news within the issue of health overall and health for women. Where we look at the sorts of diseases and health conditions that killed or made women ill in, say, the 1990s that you're seeing on the screen versus what we're seeing in 2021. And bear in mind that you're seeing in 2021 the data from the Institute for Health Metrics and Evaluation, University of Washington. Those data from 2021, of course, take into account COVID, and that's where you see COVID as these number one. But what you all overall are seeing is a very important shift called the epidemiologic transition, the demographic transition, which combined have made it such that women around the world, with very important exceptions that relate to serious inequalities, but overall are seeing a shift from so-called diseases that are more related to underdevelopment or maldevelopment and to the diseases of poverty, maternal and child health related causes of death, to the more complex chronic conditions that we call so-called non-communicable diseases, cancer, cardiovascular illnesses, and others. Now, while these are important harbingers of things that have improved for women, because rather than dying of those acute diseases associated with poverty, we are living longer and we have a lifelong struggle, as do many in our world, with complex chronic non-communicable diseases that tend to be harder to manage, more costly, and more challenging for health systems. But we forget certain things, the so-called misconceptions. We forget that women who continue to live in poverty suffer more from both the so-called communicable and the non-communicable diseases, as you'll see in some of the slides in just a moment. Next slide, please. This is the idea that titled More to Life Than Death, because what we're seeing is a shift in the burden of disease associated with disability as opposed to mortality. And you see these in several of the causes that explain the burden of ill health among women. Here you're seeing it for menopause, endometriosis, maternal and health related challenges, osteoporosis, and then breast cancer, but I'll speak a little bit more in the future. But again, this shift from over time, mortality to disability related. That means we speak about a lifespan and a life cycle of health, that women live longer than men in this case, but, and these are the differentials we see between women and men, that women spend 25% more of that time in poor health compared to men. And we're citing most of these data from the 2024 report of the World Economic Forum and the McKinsey Health Institute. Then we have the so-called visibility factor, that acute deadly illnesses create urgency, and chronic diseases with high morbidity can be seen as invisible or deprioritized, particularly when we're speaking about women. And understudied and underfunded. Many of the conditions that primarily affect women will be understudied and underfunded, but also the sorts of research that we've seen over time undertaken are focused in all senses, including the animal behavioral models, on men as opposed to women, males as opposed to females, really biasing the sorts of information that we have, the evidence that we need in order to be able to do the best job possible, our health systems do the best job possible in supporting the health of women. Next, please. Overall, what we find then is that women collectively spend about 25% more years living with disability or YLDs than men. And what does that mean for what our health systems need to do? Next, please. That we need to think about the sorts of barriers and obstacles that our health systems are facing that are ensuring a motor behind making this continue to be the case as opposed to working towards the gender equity and equality that we'd like to see. This is a particular way of presenting this that I think is very cogent. And I call it the vicious cycle of maldiagnosis. So we have misdiagnosis, first of all. It's 7 times more likely that a man who has a heart attack or a heart condition, we misdiagnosed or discharged during a heart attack versus a man versus a woman. That there are much higher chances, if we take the case of menopause, of misdiagnosis due to some symptoms being mistaken for other kinds of conditions. We see something similar with breast cancer. We have a woman who comes in, says, I have a lump, it could be cancer, and it's almost always diagnosed in certain parts of the world in particular as being an infection as opposed to a likely breast cancer, particularly if that woman is poor. The second part of this vicious cycle of maldiagnosis is the idea of underdiagnosis or missing the warning signals. The breast cancer is another example of that. But the most patients, here are 2 examples, with signs or symptoms of suspected preeclampsia are not diagnosed with preeclampsia, although they clearly have the condition. And one other example, polycystic ovary syndrome, which affects 16 to 13% of reproductive age women worldwide, goes 70% undiagnosed. And finally, or late diagnosis, which means necessarily a greater health burden for women and also typically a higher likelihood of dying from the disease. Here are some important data that from a study base that was done in Denmark over a 21-year period, there's diagnosis that is later for women than for men in 700 different diseases. And when that's broken down disease by disease, women experience delays in diagnosis of 2.5 years for cancer overall, 4.5 years for diabetes, and that's complemented with some data that we have from the UK in this case, which is 8 years of delay with endometriosis. Next slide, please. I wanted to share a little bit of the work that we've done for Mexico on breast versus cervical cancer that I think highlights some of these trends and ideas and challenges, as well as the opportunities and the bright side of what we see in women's health. These are data over more than a 50-year period for mortality in Mexico, a country where I do a lot of work, and one in which I've lived breast cancer in my lifetime. 2 things to highlight here. First, from the 50s to mid-1980s, the blue line, cervical cancer, yes, a cancer, but a cancer that's associated with an infection. So in some senses, a so-called communicable disease, the mortality rates were going up through that entire period and have now dropped to almost half. Now, this drop happened before the HPV vaccine, so we're seeing many important developments, including awareness and earlier detection among women, necessarily poor women agreeing to go through invasive examinations, knowing that this can save their lives, and the good news of what happened with cervical cancer in this case. We still see high rates, particularly in poor states in Mexico, but again, the curve is on the downward trend. When we compare it to the communicable cancer, the cancer for which we don't have an associated infection, that's the breast cancer, it's continually on the rise in terms of mortality. And around 2006, more women in Mexico were dying of breast than of cervical cancer. Although, again, if I looked across the states, we would see a high concentration of cervical among the poor states and less so for breast. Poor women overall die more of both cancers compared to others. Next, please. And then to go to one piece of particularly good news, again, on the topic of breast cancer. If we looked at what's happening around the world, and again, this is a complex, chronic, costly disease, breast cancer, in the United States, Canada, Australia, and many other high-income countries, over the last 30 years, a 40% drop in mortality, which is an incredible piece of progress. It's associated with awareness building, earlier detection, and more and better treatment, but better access to that treatment as well. So it's got all of those 4 components combined. I showed this figure because I think the sorts of questions that we have to ask is in countries that are considered of lower income, lower middle income countries, in this case, I've got Brazil, Colombia, and Mexico, and I'm sure that Dr. Ferrer will have more to say on Brazil than I can. The question for these countries is, how can we take advantage of the science? How can we ensure that more women have access, and that the obstacles that would prevent them from otherwise getting access can be broken down? Now, in the rest of what we're going to do today, we're going to speak not specifically to this issue of cancer, but using that as the example that I had shared. Each of our panelists, Dr. Henry and Dr. Ferrer, who I'm going to call Amanda and Carolina, and hope they'll call me Felicia going forward, we're going to speak and go into a little bit of depth about some of the issues underlying this across the board for the health of women and across the life cycle. And so we want to start with reframing the definition of women's health. And I'll just start by saying that one of the issues in reframing the definition of women's health, I think, is to think a little bit better about this idea of what is maternal health, because many women are not mothers. Many women choose not to be mothers. And so what is maternal health? And also maternal health goes beyond that, very complex process of giving birth in the early years of life. And we see women surviving beyond that and having many different sorts of issues that are not at all related to their process of being mothers. And what does that mean? And how do we think about redefining that issue of those different issues of women's health? What we're going to start with, and I think we'll begin with Dr. Ferreira, is to speak a little bit about what are some of the most prominent and pressing disparities and challenges in women's health in Brazil, or that your work addresses in Brazil and overall around the world. Over to you, Carolina.
So hello, everyone. As you mentioned, I'm a Brazilian gynae, and also I'm expertise to work in remote areas of my country and also in the Middle East. But I will talk a bit more from Brazil. That is the place I'm living now. And I'm working in a remote area. It's called Ilhéus. It's a small city of state of Bahia. So just everybody knows, Brazil is a very big country. So we have a lot of different ways to assess health. And also we have a very challenge between the regions and the places, big cities and remote areas. So sometimes our numbers is really different between our regions. First of all, I want to talk a bit about the ways to get healthcare. So we have like 3 ways basically to assess health here in Brazil. The first way is the private. The private health, we have like very good resource, very good doctors. So we can do all screenings, we have access of ultrasounds and all complex things. But you need money to assess. And we have just a small part of the population that have the opportunity to get this quality of care. The other way to assess health here is the health insurance. That means that you pay monthly amount and you receive care when you need. So in this, we have different levels of care, like more you pay, more you receive. But like we have a very high number of C-sections, for example, in this kind of access, because we pay not too much for the doctors. So the doctors perform a lot of C-sections. That means they have less time to spend. So in 2022, we have 82% of deliveries in the health insurance were C-sections. So it happens because the money of the doctors and also about our culture of C-section, which is increased by the doctors' attitudes, and also we have a very high rate of obstetrical violence, so makes the woman with some fear of delivery, of normal delivery. So this number is high, and we know it increased 3 to 4 times the rate of maternal death. And also we have the public health. The public health is completely free. And the most of the population needs the public health. In the public health, you have very limited resource, like sometimes we don't have medication, we don't have rooms in the hospital, we don't have enough doctors to attend the population. So just for numbers to know, we have like 6 doctors per 1,000 people in Brasilia, that's our capital, and 1.3 doctors in Maranhão, it's the north of the country. So in this kind of health, we have limited access to antenatal care. We have also a very low number of hospitals. So also geographic conditions here, like in Amazonas, we have problems to transportation, we have forests, we have rivers. So it's very difficult to access the hospitals. We have there are places that you don't have doctors enough. I worked in a place called Portel. It was in Amazonas. And in the hospital that we have just 2 surgeons that are to perform C-sections and normal delivery, anesthesia, and the surgeons. So it's very difficult to work. They were used to work 15 days without break. So the quality of care, of course, is not good. The place that I live, it's a hospital that was built to attend 20 cities. But the problem, the area is so high, so sometimes the woman needs to travel around 5 hours, 4 hours to get the assistance. So we have some cases like when you have start the convention in a small city, like in eclampsia, and she needs to be transportation around 2 hours to receive care. So she arrived in a very bad condition in our place. So it's very difficult to do the correct management. So it increased our maternal death and the quality of care. Also, I want to mention one study about the regions of Brazil that north and northwest is like we have the high rate of maternal death besides the south and the southwest. So that's one of the challenges we have here. We have a lot, but I think it's the principal ones.
Thank you very much, Carolina. Can you, just for the group, can you explain a little bit more about obstetric violence? I'm sure we're going to touch on the issue of violence against women throughout this panel, but so that everyone understands, what did you mean by obstetric violence?
Yes, it's a huge problem here, like the woman sometimes is not well treated. So they don't some places they don't receive the anesthesia. They say they need to delivery. We have some practicals here that we know it's not. The studies show that you don't need to do this. So room and don't receive the quality of care. So it makes the woman with a lot of fear of the normal delivery. It's really common. Brazilian women say, oh, I don't want a normal delivery because I have the fear. I will have a lot of pain. The doctors won't treat me very well. So sometimes when they have money, they pay for a C-section. So it's just the problem of our culture. It comes from a long of I think so many reasons. It's so many years with this. So from now, the studies show about this violence makes the fear of the woman, and sometimes they have the option when they can for a C-section, and so we have a lot of deaths as a consequence of this.
I think that's so important that you're highlighting for a number of reasons. The issue of giving women information, the issue of giving women choice about the sorts of interventions, and that issue of access to pain management. We hear over and over again things like women don't feel pain the same way that men feel pain. Children don't feel pain. You know, I've done a lot of work on this issue, and there is no evidence that we do not feel pain. We feel pain, and how we
Yeah.
treat pain should not be gendered, shall we put it that way. The other is just to highlight, I think you're speaking and very openly about something that's very common. We call it machismo in Mexico. We call it different words, but it's around the world. It is not unique to Brazil. But also this idea of fragmentation in the health system and lack of access. So science without access doesn't save lives, right? And with that, I think I'll turn it over to Professor Henry to comment on this point. Amanda, please, over to you.
Okay, thank you.
Thank you.
Great, thanks very much. So I'm based in Australia, which is obviously a high income country. We have our very strong Medicare system, so essentially universal healthcare access for citizens and permanent residents. However, there's still absolutely, you know, disparities within our, you know, very fortunate, very privileged overall system, our priority populations like our First Nations, like our migrant and refugee populations, and again, those who live in the regions, so, you know, rurally and remotely. And I should also acknowledge that, you know, Australia, we're in a sort of a very fortunate system, but our neighbours in the Pacific and the global south, there's also still huge disparities. I mean, Papua New Guinea is only half an hour or so off our northernmost coast, and you know, things like maternal mortality and cervical cancer death rates are, you know, 10, 20, 30 times higher in our nearest neighbours than they are in Australia. So, you know, access is a huge problem. But even when, you know, we're in a universal or near universal access type system like Australia, you know, as you said, Felicia, if you don't, you know, translate the science and translate the evidence, if you don't have your systems of care appropriately set up, then that's still a huge problem. And I guess what I wanted to highlight is what you were sort of drawing out in those initial slides about the need to recognize that non-communicable diseases are actually now by far the biggest cause of premature death and women's disability globally. Yes, we live longer than men, but we live much more time in poorer health, and we need to get, I guess, beyond what we often call the George bikini medicine. So, you know, just focusing on the bits that are covered by a bikini, and onto like a life course approach to women's health, which doesn't mean that those various touch points, you know, unique to women, like the onset of menstruation as an adolescent and things that might come with that, or pregnancy, and, you know, having safe, healthy deliveries, or, you know, menopause, and dealing with sort of acute issues around all those things. Doesn't mean that's not critically important, but we need to recognize that those times also give us critical windows into women's future health, and what happens in those various really important lifetime points aren't siloed. It's not like, okay, well, it's, you know, it's all about the pregnancy, trying to have a healthy pregnancy, a healthy baby, move on, because actually we now know, and in fact have known for quite a long time, we just haven't acted on it, that, you know, what happens in pregnancy, and this is my major area of work, has potentially, you know, major impacts on women's lifelong health. So pregnancy complications like high blood pressure, preeclampsia, gestational diabetes, all convey, you know, increased risks of non-communicable diseases like kidney disease, type 2 diabetes, cardiovascular disease. But we're still in that sort of acute medicine sort of siloed look at women's health. And so we need to sort of, you know, rethink our systems so that we're not seeing, you know, women's reproductive and sexual health in isolation, but that we're seeing it as kind of part of a life course approach. So our systems, wherever they are and whatever we have to work with, we need to have a longer term view. And also, you know, we need to actually not just do what I call admiring pathology. So 20 years down the track after preeclampsia and the woman has a heart attack, going, oh yeah, that's a thing. There's a relationship between those two. We have to stop just admiring that, and we need to start treating it, treat pathology. So early intervention, working out what works, working out how we, you know, risk predict, and then retooling our systems of care to focus on women's life course health.
Thank you so much. And I think let's add, and having women be part of that process of figuring out what works. The bikini medicine, that's a phrase I had not heard before. And, you know, for those of us who work, it's great. For those who work on breast cancer, it's almost like topless bikini medicine, because I'm not even sure there's the top to it sometimes, interestingly enough. No, I think that is a very important way of thinking about it, for good or for bad, and will certainly guide quite a bit of the rest of our discussion in a lot of ways. But let me just summarize by saying again that I think we're speaking about, you know, over and over again, health systems where certain groups of women within women overall have particular challenges and obstacles to access. So while we think there are gender-related obstacles that affect virtually all women, there are groups of women that have layered obstacles. In addition to being women, they are poor, they come from particular populations, they come from rural areas, they can be race, it can be religion, it can be many things, but they layer onto each other. I'd like to turn us now to a discussion of the approach overall and build on what we've been speaking about, and sort of go to the need for a holistic approach to the health of women. And so let's talk about some of the consequences of not looking just at avoiding premature mortality, but also thinking about disability. But I'd go beyond that, thinking about the life course, thinking about the quality of life, thinking about what it means not to suffer excess levels of distress in all aspects of our lives. In short and in longer term, we talked about pain, but it can also be not suffering additional economic distress, not being forced into catastrophic payments or impoverishing payments. That's also a kind of distress. So there are many aspects, in addition to premature mortality, that we need to think about. And so I think I'll turn back to you, Amanda, Professor Henry, to talk a little bit more about this in relationship to some of the work that you've done.
Sure, thanks, Felicia. So I guess to expand a little bit more about sort of pregnancy as a predictor of future health risks, and you know the sorts of things that we need to be looking at, and acknowledging, you know, as you said earlier, there are many women who will never be pregnant, either, you know, by choice or by circumstance. So I'm not, you know, this is a very important area, but of course it's only one area that's very important. And I also just, I guess, before I get a little bit more into detail of some of the things we need to be watching out for in this topic, is just acknowledge about the sort of, disparities amongst subgroups of women. And I think, look, overall, women's health and research on women and research into our systems of care has been plagued by the fact that men are the default humans. And, you know, the white male is the default human. But I think we also need to acknowledge that when it comes to women's health, that the default woman is usually the white woman, and often the white higher socio-demographic. And what works for that woman can't necessarily be extrapolated across. And in some ways, and a colleague from Queensland Health, in fact, one of our regions in Australia, who was talking to about this issue in their women's health program, they're actually trying to flip the dial and say, well, if we get it right for our priority populations, like our First Nations, like our migrant, like our women working in the regions, then actually, if we do that, then it'll flow on for the rest. The white woman will be fine. Well, woman will be fine. So yeah, look, in terms of pregnancy as how we need to work on this sort of life course approach and break out of our silos. So obviously there are major important acute complications of pregnancy, and globally there are still pockets where there's extremely high maternal mortality, and not forgetting about that at all. But now, as for overall life, like what comes afterwards, non-communicable diseases are actually much more of a threat to women's health and well-being. So, for example, hypertensive disorders affect 5 to 10% of pregnancies, gestational diabetes about 1 in 7 globally. And in terms of the long-term health risks here, for after hypertensive pregnancy, tripled rates of chronic hypertension, doubled rates of heart attack and stroke, 5 to 10 times the risk of chronic kidney disease, at least doubled risk of type 2 diabetes. And that's just for what we might call garden variety, in inverted commas, term sort of preeclampsia. There's additional, risks if preterm, if multiple episodes, etc. For gestational diabetes, probably sort of 7 to 10 times the risk of type 2 diabetes, and double the risk of cardiovascular disease. And really importantly, this is not like the difference between having a heart attack at the age of 83 versus the age of 84. These sort of increased risks are evident within 5 years of affected pregnancies, and they continue lifelong. So we really need to be looking at our systems like beyond a 6-week maternal checkup or whatever is funded in your region, to say, well, so what happened in the pregnancy? What does that mean for ongoing health? And beyond just the instant maternal infant health, and kind of taking that life course approach. And yeah, in terms of our priority populations, we still have so many where we actually need, we need more data as well, because they're almost certainly more affected than our default, as it were, in inverted commas, white woman. But we still don't, have some of the evidence to help close those gaps, both for individuals and it's on a systems level.
Oh, that's so important. So we've gone from a place where we, were so concerned that there were only white male mice. And now right, and then we went from white male mice to we wanted female mice, but now we want different kinds of, which is exactly what we need. But I wanted to share something that I found, I think speaks to some of what you were sharing with us. I remember when I was doing some of my first work on how to do breast clinical exploration and what to share with women about breast cancer. And all of the material had what I would call Barbie breasts, going back to the bikini mentality. They were pink, they were small, they were perky, and they were in their early 20s. And we were working with women from communities. They had 5 children. They were on the larger size, and they looked nothing like anything in the materials that the health systems had developed. So they said, no, this is a disease of that kind of women, not of this kind of woman. But in addition, we were doing a terrible job of training our primary care personnel on how to do breast health and breast exploration, because we weren't training them on how to manage the reality of what was for most women in most periods of our lives, which is to be different than what I might call Barbie breasts. So changing the materials, changing the training, changing the medical education, and how these sorts of misconceptions can be so pernicious in terms of helping women to face potential challenges and avoiding that idea of maldiagnosis, misdiagnosis, undiagnosis. The other thing I just wanted to highlight in our conversation, and I think it feeds into what you were talking about, is the issue of trauma and violence against women. We know we're speaking about at least 1 in 3 women, higher in some communities, at least 1 in 5 girls, probably more in some communities. And this affects all aspects of life. It increases the likelihood of other kinds of chronic and non-communicable diseases, and it has an intergenerational impact in so many senses, including, we think, at the cellular level because of the mental health impact. So what we're seeing in some of these complex, difficult, traumatic pregnancies is also the result of serious and pernicious, inexcusable violence against women, which is an underlying cause of so much of the ill health that I think we're seeing and trying to cope with and need to cope with it at the outset. But I want to turn it over to you, Carolina, to comment on this idea of a holistic approach to women's health. Please, over to you.
So I saw so many things here in Brazil, as you mentioned. So we have the high rate of mortality in Black population. As I started to talk, we have the different regions of Brazil. So we have the southwest and the south. We have here more white population and like well-developed place. And also in the north and northwest, we have more Indian people, Black people. So we have the different treatment from them, different access of health. So it's really clear here we have this difference, as you mentioned. And also we don't have like antenatal care, no family planning, no support for the woman to plan her life. Like, so we have like an expected pregnancy, and also we have a high rate of sexual violence. And as everybody knows, Brazil, we have illegal abortion. So even in the case of sexual violence, it's legal, but it's really, really hard to have the access to the service. So the hospital needs to do, but normally the doctors refuses to do. And also the woman goes to judgments, like they look to her as a criminal woman. So they try unsafe abortion. And also it's like we have a high rate of death from this kind of woman. So here in Brazil, there's disparities and the underdiagnostic is also, as Dr. Henry mentioned, diabetes, hypertension. We have our first case of death here in the maternal death is hypertension. In the word is hemorrhages. So here we have hypertension. And we saw the doctors didn't find the risk to receive the treatment, the prevention. So also diabetics, we just do sometimes the diagnostic. Oh, sorry. I think it's okay. Okay. So we find that sometimes we do the diagnostic in the maternity. So with all the complications that could be avoided with antenatal care. So here I think we have a lot of these disparities between the woman.
And also this, underlying and vicious theme there of, the blame the woman. And where the actual illegal activity and what is criminal is very gendered in this context, of course, as well. So let's go on and making good time, because we want to make sure that we have some space for questions and thoughts and comments from all of you who are listening to this panel. So please go ahead and begin to share those. We'd like to go on to our third topic, which is around strategies for lifelong well-being of women, because we want to take an approach that goes, again, all the way through the life course and includes, which is very important, women who are in later stages of life who are not going to be producing babies necessarily and are still and want to be and can be and should be very important contributors to their communities, to their societies, and have all of the opportunities available to them to be able to enjoy that stage of their life, but are often pushed aside at the point where they're much less valued later in life. So another layer of discrimination on them. They're older and they're women. So let's talk about the lifelong well-being of women. And tell me a little bit about, within the work you're doing, how you're addressing the challenges of lifelong well-being, and if there are particular tools we'd like to share with our audience today that you have found to be especially effective in your work at thinking about lifelong well-being of women. And Carolina, let's go ahead and start with you.
Here we have some programs, like you have government programs, first of all. So we have one program that calls Mais Médicos. In English, it means more doctors. So the government tries to bring doctors to rural areas. So they try to get all over the world doctors to these small areas with good salaries, good opportunities. So it's one of our programs. Now we also have for the government a new program. It calls Rede Aline. Aline is a woman who died during her pregnancy because she didn't have access to health. So it's created last year. They promised to reduce 25% maternal deaths until 2027. So they try to increase the money for maternal case, for women's health, and also the constructions of maternities and places for low-risk deliveries. Also, for the government, I want to share, it's like a very small program. We have a small city near I live, that we have an experienced midwife that she is responsible for trainings, family planning, and also the instructions for delivery that we mentioned before. She does this, like she can do the support for the woman. She explains how is delivery. So with this program, we could reduce the last year % of emergency, and we refer the woman in the correct time. So this program, it works very well, but it's so small in our country. Also, we have some projects that I work at also. It's from NGOs. We have a lot of volunteer doctors that go to these remote areas to try to bring the quality of care. So I will mention just 3 programs that I participated. One of them is Instituto Dharma. They do primary care in remote areas, so they could bring equipments like ultrasounds and also specialists to perform the diagnostics in remote areas. Also, I work in Expedicionários da Saúde. They try to do the treatment of cervical cancer in Indian population. It's the Amazonas area. So there is another program. And also I work with Doctors Without Borders around the world, but specifically here in Brazil. I work in Portel. It's a small city at Amazonas, and they try to reduce sexual violence because it's an area that we have a lot of, it's Marajó. Also, it's in TV, also they say because it's a really high rate. So they try to, like the approach of the program for the woman. So there is some strategies that I know here. I couldn't say everything works especially for the government. Sometimes it works in some area, but not the whole country, but they are trying. So that's the thing.
Yeah, so I want to highlight that you said they're very small programs, but often what we can see with a pilot program, if it's well evaluated and studied, is that's how we go to scale. That's how we find out what can work, and I think that's particularly important. The other is that it's not necessarily the most expensive interventions that are going to be the most effective by any means. And so I think you're speaking of times where we are looking through what can a primary care provider, what can a nurse, what can a health promoter do? And we have, ample evidence over time that much can be done, particularly to avoid misdiagnosis and late diagnosis, and to assist with referrals for women who have challenges related to their health. So the idea of what can be done at the level of the community, again, the primary level of care, is very important. And the other is, and we haven't had a chance to speak about it very much, but of course, there's an incredible opportunity that we have with telemedicine, and to some extent AI. And while COVID generated a kind of suffering and health that the world had perhaps not seen for a century, it also gave us an opportunity to leapfrog into a space where we could see insurance and we could see opportunities to be able to communicate, as we're doing now on this webinar, ways that we could never have done before. But that does translate and should translate into increased access to very high quality, including specialized medical care for women living in all different circumstances. So it can change the access vector and equation in ways that we could have only dreamed of pre-COVID. But Amanda, I would like to turn it over to you.
Great, thanks. So I'm going to talk a little bit about some sort of general systems stuff in Australia, and then my own, obviously, body of work in how we're trying to use the Pregnancy for Lifelong Health program. But so in terms of kind of general, the gender health gap is something that actually has received quite a lot of importance in Australia in recent times, long overdue, and it's great that we're getting there. But there's some gender health gaps that are not so obvious, and some that really are. So one for general issue that's not so obvious is about sort of consultation times in family practice, and what's rebated. So we have the sort of 6-minute medicine here, because that's kind of what it's been calculated, that for the the rebate that GPs, that family doctors get, that's how quickly you have to turn it over. Well, clearly you can't do an in-depth consultation or go through someone's chronic conditions in that sort of a time frame, and that would seem to apply to everybody, but because women have overall often more of these chronic conditions, they need more of the longer consultations. And so if you don't appropriately fund, long consultations, then that's actually a gender health gap roundabout. Other things are a lot more specific. So for example, our ultrasound rebates, what the government will pay providers to do ultrasounds, you basically make as much or more money for doing a testicular ultrasound than for sort of the full pregnancy, screening ultrasound or a gynecological scan, which clearly the time taken is nowhere comparable. And again, we're slowly making kind of inroads on that. So our most recently there's a proper increased rebate for ultrasound to look at to screen for endometriosis and to do an in-depth scan. So that's, I guess, just some things on an overall level in terms of women's lifelong health. In my sort of particular area, so the issues that we have are the in terms of preventing chronic disease after pregnancy complications, first of all, better evidence about what works early, not just, looking back 20 years later when bad stuff has already happened, but actually, what is the evidence to prevent that? Because largely that's actually been extrapolated from, older adults with hypertension who don't necessarily have anything like the same competing demands on their time that, a new mum does, for example. Risk prediction and, how do we work out who we focus the most on is another area. And then also closing sort of knowledge gaps for both women and healthcare providers, but, involving all of them in the journey with co-design, because, it doesn't work if you just work on women, not with them, and likewise with our healthcare providers. And then the sort of the systems change in terms of, valuing, the time, like as in we, as a government, for example, you say, well, we'll give proper time for a longer postpartum consultation a few months down the track to look at those things, for example. And I want to emphasize, and our group is kind of, and many others, both in Australia and globally, are working on this really important topic. I do want to emphasize that it's not a menu in terms of like you pick your favorite item and just try that. You really need like all of these strategies to make progress. So yeah, our team and our collaborators locally and globally are doing all of those things. We're doing sort of early intervention studies, systems of care follow-up. We've been working on kind of co-design with women and healthcare providers in terms of, okay, what do you need to know about health after medically complicated pregnancy? When do you want to know it? How do you want to get it, etc. And also with our scientific colleagues on getting a better understanding of who's most at risk. And I guess that's where, we touched just a little bit on digital health and AI. And so that's certainly one area where we can, certainly that can be part of the closing of those knowledge gaps. And we found through our work that women do value some post-pregnancy care through apps, social media, online platforms, but they need to know the information's reputable. And also most women, and this might be a bit context dependent, but certainly in Australia, the women that we, interviewed and got surveys from had a very strong preference for their family doctor or their healthcare provider, midwife, OB, whatever, to know this information and to have a consultation with a real life human about their issues. But they were very happy to have, reputable digital health to kind of go along, with that, to help close those gaps. Like I said, might be a bit context dependent. With partners in China, we had a look at women, Chinese women after gestational diabetes, and they had a much stronger preference for the sort of the digital mHealth type applications and things, maybe less so in terms of face to face. So you again, it's not a like one size fits all. You do have to look at your own context. Healthcare providers also want to be able to use reliable digital tools. And there's certainly the global work of some of my colleagues at the George Institute looking at a tool called Smart Health Pregnancy, which we've used in places like rural India with the ushers, the healthcare workers, where there's access, digital inbuilt for these workers, handheld devices, giving them access to various, so what issues have women had in pregnancy, postpartum, and then, where do we go? And in terms of sort of AI, I think, AI, as somebody said to me when I was on a grant panel recently, and AI algorithms, etc., for was fertility care, actually, I think came up. AI is not magic. All right, we do have to be careful that we don't reproduce the biases of the past in our AI tools, and we do have to be very careful that they're that to avoid the false information, the hallucinations, privacy, all of those things. Again, one of the things my group's working on, and this is not just the pregnancy space, this is more that life course health, is something called Ovum AI. I've got a PhD student who's developed a sort of a personalized women's health assistant, so for women to have control, to be able to input what they want about their health data, and again getting the beyond bikini health, all conditions, not just there's a fertility app for your ovulation chimer and so on. So I think there's huge potential with digital health and AI, but we also have to remember it's not magic, and doing it badly can actually increase health disparities, not decrease them. Yeah.
So, I mean, absolutely. And also, I mean, thinking about the technology divide as well, that women who are in older or later stages of their life may be much less familiar with how to manage the technology and be much more able and needing of a face-to-face. So incorporating those biases and thinking about the word used, co-design, and so patient and people co-design of health systems is, I think, really that way forward. I think you also highlighted a point that perhaps we'll continue to say more about, which is that money does matter. So the incentives that we give providers to do certain things are important determinants of whether or not they do them. If you are paid less to provide the services that are required by women compared to those that are required by men, you are typically more likely to provide the services that are better paid. The same we see on C-sections versus natural birth. So money can matter and does matter as an incentive to undertake and to have a health system that's responsive and that makes up for many of the entrenched biases that we see that are such important determinants of the health of women. Now, if both of you are in agreement, I'd like to give about 20 minutes to get some Q&A from those of you who are listening. And we would be pleased to field and discuss with you questions, comments, suggestions, and maybe you have some of those that Ken can help share with us. And if not, we can continue discussing because the three of us don't always get the chance to discuss.
Oh,
Are you?
There is a question there. Yeah. Oh, yeah.
You know what, Amanda, if you can see it for some reason.
I can see it.
Please,
yep.
Go ahead.
So the first question is, what changes in general in women's healthcare would you like to see for a more positive future? All right. I'll
Do you want to go on that one?
Yeah, okay. I'll start with this one. Look, I think it's many of the things we've touched on. I do think that seeing that the beyond bikini health and a life course approach to women's health is really important, and that getting away from seeing women's health as sort of snapshots in time. Okay, your periods have just started and you've got irregular or painful or very heavy periods, and let's deal with that with no kind of reference to anything else. Or you've had you're pregnant and just kind of focusing on getting through that, but not thinking about or in menopause and okay, what do we need to do to treat hot flushes, but not thinking of that as a touch point for, okay, so, what are our cardiovascular risk? What's our bone mineral density? How's your mental health? So that I think is really important. And that requires overall changes on, individual level. In terms of our healthcare provision, it requires us to break down some silos. It's not, well, the hospital's problem or the family care practitioner's problem or the nurse midwife's problem. Like, we're all responsible for all of it in some way. And then obviously systems change, and partly that is of course money and what you value, but it also comes in with that co-design. How do we use tools better and smarter, be they face-to-face, digital, etc. So I guess those are a few things I would say. And sorry, I would just say one more thing is also another, I think, barriers that we need to break down, and we've kind of touched on this a little bit in terms of thinking about gendered violence, is that it's women's well-being as well, not just women's health. And your housing state and your social circumstances and the education you have available to, and whether you have food security or not, and whether you are experiencing intimate partner violence, for example, they're all there's health conditions, there's also structural overall conditions, and it's not one or the other. We need to think about women's health and well-being.
And I think that fits so into the idea of the social determinants of health, right? And we know that changing the social determinants of health can impact in a much stronger way often than the actual treatments can. So it's looking at the root causes as well as the manifestations, and to treat so-called the problem, as well as the disease in this case, but as well as the lack of healthcare. The other, and I know we're going to speak about this, and I'll share a little more day two in a few minutes, but the majority of individuals around the world who provide healthcare are women. And the context in which they work and they provide healthcare to women and to others reflects the biases, the discrimination, sometimes the harassment that we're speaking about, that is a general determinant of the health or lack of health that women experience throughout their lifetime. So I think one of the most important ways to see a more positive future is to account for the labor force discrimination that we see in the health sector, where again, the majority of those who are providing healthcare are women. And we have so many individuals in our world who lack access to a healthcare professional. And we have so many women who are trained as nurses, as physicians, as social workers, as other providers who lack access to work. So you have people without doctors and doctors without work, and the majority are women. And we have to ask the question, sort of why and what we can do about that. But Carolina, maybe you want to jump in on this sort of double-barreled question that includes AI as well.
So the second question, yes, do you want to read?
Either,
Yeah.
it's a two-part, it's a two-barreled question.
Yeah. So I think for AI, it's really, really important to remote areas. As I mentioned a lot, that you don't have doctors, you don't have expertise. So sometimes here in Brazil is really common, like you have a machine of ultrasound, but you don't have a person to perform ultrasound. So that don't make sense. So I think you have to some telemedicine, AI, we can do the training, we can answer questions like protocols when you have warning signs from the woman. So if we can do this with people who are not so expertise, but could give good healthcare. So I think that's the way you can train it.
You know, and this is if we pay people who provide healthcare to women less than we pay people who provide healthcare to men, then we are bound to see these biases, you know, reflected over and over. And let's see, we have another question, and I've managed to put it up on the larger screen. It says, "Dear Dr. Carolina," this individual is from Sao Paulo, "and I know the difficulties we face in our country, Brazil, but I'd like to make it clear that despite regional inequalities, we have excellent services, even public and mainly free, through SUS, that in big cities serve the population of the whole country with quality standard that meets and often exceeds international standards." And I'm not sure if that's the second part of the same question, but happy to have you comment. And I'll also, you know, highlight that I asked Carolina to comment on Brazil, but also more broadly, and that we were, you know, sort of very careful to say that when in each of the countries we work, there's excellence in the provision of care, but not universal access to that care for many. But Carolina, maybe you want to comment on that.
Yes. I try to share this in my presentation. I think our program and public program is really, really good. So, like I'm from São Paulo now. I'm working in Bahia. So we know that we can provide a lot of healthcare, but it's really, really different between in the place that I live, the only hospital we have is a public hospital. So it supports the whole population. We don't have the chance to have a particular private places there. So it's a very good program because it's the only way to get the access is the public. But I think I'm trying to say the difference between the regions is very high. So that's why I try to transmit as our challenge. If you have the healthcare like São Paulo in the other areas, I think it would be amazing. So that's the thing I want to share with the audience.
Right. And no system is perfect. And I say this, I've done most of my work in Mexico, but I'm Canadian by birth. One of the healthcare systems that's considered, you know, one of the strongest in the world. And one of the things we most like to do, which is most important as Canadians, is to criticize our own health system. And that's in part because, you know, health is always an aspirational goal. We should always want more, right? And this is a constructive kind of criticism to increase access and improve outcomes, because I don't know a single health system in the world that can't do better. And I would say, particularly the one where I happen to be sitting, which is the US health system. We can go into that or not. But I do want us to go to the next question. What is the correlation, if at all, between financial independence and health, if at all, if there is any? And let's say I want to make I'm interpreting this question properly. We're talking about the financial independence of women, but I would say we also need to think about financial independence, or the ability to be able to afford access to healthcare without risk of impoverishment or catastrophic health spending, which I think, you know, we've all worked on in our careers and is particularly important. Let me turn it over to either of you, and then I might comment a little bit.
Yeah, I'm happy to briefly comment. I guess you may want to emphasize, Felicia, that this probably is going to be gone into a whole lot more depth in tomorrow's webinar. And yes, our colleague, Dr. Downey, who's a health economist, is ideally placed to answer this. But yes, there is absolutely a correlation between financial independence and health. And for women's health, one of, you know, globally the inequity issues is that, you know, women are often not in the position of being the decision makers about spending on healthcare. I mean, there are obviously some countries and societies where, you know, they actually need their male relatives' permission to access healthcare at all. But even when it's not that extreme, there's very good evidence that in times of scarcity, that the health of the women, that the females in the family tend to be under prioritized compared to those of the male, whether children or adults. And yeah, so, you know, it's really important. And even in, you know, high income countries like Australia with, you know, supposedly pretty universal access, there are still out of pocket costs, and it is sometimes a choice between, okay, are we going to make that visit to the GP? Are we going to pay for that prescription? Or, you know, are we buying food for the next few days? And yeah, so it's a big issue for everybody, not just women, but it is an additional issue for women's health because of the overall you know, less control and lower degrees of financial independence, including when it comes to making health decision making.
And economic violence is a kind of violence and a kind of abuse, and can be waged against the woman regarding her health or her need or commitment to her children's health as well, or her own parents' health. So that kind of economic violence, if waged against a woman, will stop her or her immediate family from getting the care that they need. And I think, you know, when we were in the pandemic, we heard over and over again the stories of women who cared for men with COVID. The men would get care and the woman would not, even though she was bound to contract the disease. And how did that happen? It was control of resources, right? But Carolina, did you want to comment on that?
For me, I think it's a really high correlation, like also mental health, as we mentioned before, when you are like, we can do like more quality of life. So I agree with everything Dr. Hen mentioned and you.
And I guess I'll add, so one other learning is that what we will see women doing over and over again is not investing in our own health, because we invest in our families first, right?
Yes.
And we always hear that adjective, those of you who've been on an airplane, they say, remember to put on your own mask first before you put on that of the child. You know, so over and over again, I will hear that a woman did not have a mammogram or didn't go for a checkup because she was caring for her children, because she used the money that was available to care for them first. Well, this is laudable and important. You know, our own health is also a value. And when there is scarcity or lack of access, I think we forget to prioritize ourselves. But I know we're going to speak more tomorrow about catastrophic and financial impoverishment and how to structure health systems. So I want to go on to the next question. As a person new in clinical research who wants to help better women's health, where should I start? Or what CROs should I go for that strive for that? And I want to make sure I'm following this. And, you know, I think, well, I'll turn it over to panelists, but I think also you should think of what area of health are you most interested in? Where do you want to devote yourself? Because almost any area of clinical research is incredibly important in changing that gender gap, right? So it's how you do whatever you're going to choose is closest to your heart to do. To keep those gender issues in mind. But Amanda or Carolina, maybe you want to jump in on this.
No, for me, I prefer Dr. Ren goals because I don't have so many experience in clinical research. So I don't know if Dr. Henry could talk better than me.
To be honest, I think, Felicia, you've said it mostly. It depends on which region of the world that you're coming from as well, and Yeah, I mean, there will be organizations, clinical research organizations in whatever part that will have a women's health strategy. But yes, it's, what is speaking to you, what's your, beginning area of expertise, and yeah, go from there.
And I think is I just remember to ask the questions that are related to gender. So I'll just share briefly an anecdote. When I was doing my thesis work with street children, and went to present the initial results of my work in Colombia, and I, shared with a group of amazing leading researchers and said, 80% are boys, and a wonderful researcher and a leader, Geeta Sen, said, why? And I was like, why? Well, because 80% are boys. And she said, why? And I didn't have an answer. And figuring that out turned out to be the major piece of work in my doctoral dissertation. And it turned out there were a whole series of obstacles that meant that there were all of these missing women, missing girls. It wasn't that they were in a better situation, it was that we weren't seeing them. So it's just to always ask that question. About gender, about poverty, about race, about color, when you're thinking about the research that you're undertaking. I see our next question. As physicians, what are the effective strategies we can implement to educate women patients about the accurate diagnosis and early detection, especially in the conditions that often go underdiagnosed or misdiagnosed, as you mentioned earlier? And I am sadly not a physician. I'm an economist by training and do most of my work in global and public health. But we are able to think about the health field, and I have been married to a physician, which does not make me any closer to being a physician. But maybe, Carolina, you want to say something about this. I'll turn it to Amanda.
Okay, so I think also the first thing I think when as a gynae, I try to show the body for the woman, to explain how her body works, like to her recognize like what's different in her body, like because of the gender difference. Like for men, it's really easy when to talk about the body, about the sexual, about these things. I feel for women, they are more shy, like there are some they are shy to show the body, to touch herself. So for me, the first thing to explain the body, like to touch the breast, like to show the cycle, to know what's the normal bleeding for her cycle, to explain what the family planning, how to avoid pregnancy. So to make her the own of her life, the own of her the health. So she knows when some things goes wrong. So because first they need to know the normal way, then the different, like it's different. So now I need to go to a doctor, I need to check everything, it's okay. So for me, the first strategy is to show the woman the normal way.
I think that is so important. We are often taught that we shouldn't feel comfortable knowing our own bodies. And, certainly in breast cancer, while it's not our responsibility to know if the lump we felt is cancer or not, if you know in a certain point of time what is normal in your breasts, when you see a change and you find a change, if you can access the mammogram, if you can access the physician, you can access the care system, that is how you find out, is that change serious? Does it mean cancer, or is it not serious? So we can identify changes in our own body, but we also, exactly as Colin was saying, need to feel comfortable with our own bodies, proud of our own bodies, however they are, whatever shape, whatever size. And I think we're often taught not to do that, just as we're taught not to speak up. And these are things that need to change in order to be able to empower us to fight for our own health. But Amanda, maybe you want to comment on that.
Yeah, so a few things. So first of all, I'm actually just going to say, as a if anybody online wants a little bit of maybe an overall summary about some of these things. So there's a Nature Medicine Perspectives piece from 2024, Carcel and all, from sort of our team, which is about a life course approach to non-communicable diseases in women. And part of what it goes through are the maldiagnosis, the barriers, and what we might do about it. So that will kind of touch on a lot of things we've talked about. And then look, in terms of effective strategies, so Carolina's made an excellent point there. I also just want to come back and take a little bit of a bird's eye approach in saying it's not just about the individual woman or groups of women. There are systems issues as well. Like if you can't get to your healthcare practitioner in the first place, if, you know, your societal expectations, for example, of a postpartum woman or busy, you know, working mother in her late 40s, that, you know, you're going to ignore that chest pain because you need to make the kids' school lunches, you know, that there's many layers worth of things that we need to do. But when it comes to, and it's important to not we can be very dismissive about certain groups, and this is not just women's health, it's anything, I think, in terms of, oh, well, you know, they're not compliant or they don't listen. Well, there's often lots of barriers in the way there. And then I guess, but if you're, you know, getting to the, okay, how do we design things that work? I think, you know, co-design and you know, actually asking the groups again on a broader level, and that goes for, you know, checking in with healthcare providers as well, because if we don't make things work for both those who are providing care and those who need to receive it, we're not going to get very far.
Right. And look, I think we have to say is there are parts of the world where women are not allowed to leave their homes, to be examined by a male physician, to have access to care, where their movements outside or even inside the home are controlled for many reasons. And sometimes it is part of an abusive relationship, and other times it's a societal norm that needs to change. And that's a huge determinant. We have one last question because we are coming to the end of this period of discussion. It's women experience pregnancy and menopause. Many do, during which there are clearly substantial hormonal changes. And then the cardiovascular disease risk, hypertension, stroke, or heart failure are particularly high in these different periods of our lives. So how can we address these disparities? And I think what you're probably trying to get at with this question is, how can we reduce the obstacles to access that are associated with those changes in those periods of time? Carolina or Amanda, do you want to comment on that?
Well, I guess, you know, a lot of this, of course, is my life's work. As
That's
it would
probably
be.
why they asked the question.
Yeah, I'm not sure they're possibly meaning, you know, the hormonal changes and like acute risks, for example, during pregnancy as well. And look, I think we probably hold another webinar in terms of how to, you know, how to kind of address that. If you're improving, you know, overall population health and risk factors that underlie that, including women's health, then you will overall, you know, get better outcomes. Because so much of that, the hormonal sort of, for example, of pregnancy, you know, it's like a 9-month marathon ending with a sprint of, you know, of labor and birth. And so much of that is unmasking, you know, what's already there. So if you have populations that are, you know, coming in later with more chronic disease because we haven't done our preventive healthcare for society well, etc., then, you know, then those things will be more. So it's again, I guess it's getting back to that kind of that life course approach. It's not just an individual, it's also that systems change for all of us, and a change in the way we think about things. Yeah.
Carolina, did you want to add to that? No?
No.
So I just, one small thing, which is to say that menopause is typically understudied and ignored because older women who are no longer so-called reproductive or productive are going to be undervalued and ignored. And so those two pieces are typically, going to go together. We have had such an amazing discussion. I think I'll always think about the bikini piece. And you all who have been listening have had the chance to hear, from two leading minds who do very different things and to approach the health of women with very different kinds of tools, some more research and some more publications, and others much more hands-on with some of the most difficult issues that face women's health in our world. So we are very grateful to have had the opportunity to be able to share with you and be with you in this period of an hour and a half. I'll say again, I'm Felicia Marie Knoll. I'm a professor at UCLA at the Geffen School of Medicine, and also at the Tecnológico de Monterrey in the School of Medicine and Health Sciences. I'm very grateful to Canon for putting this first in a two-part series together, and we are going to be on with you again, we hope, tomorrow. That would be starting at 7 p.m. Eastern time, and we have about an hour and a half again. We're going to be discussing in day 2 of this webinar series how health disparities impact women's economic productivity and the strategies for changing, helping, support, and working with them. We're going to be continuing the conversation with Professor Laura Downey, also from the George Institute. Amanda, thank you for being with us today. I know you've worked together, and that paper, by the way, is an amazing paper in Nature Medicine. We've all been using it, we'll continue to use it. And so we thank you all for being with us, and look forward to seeing you tomorrow for part 2. Thank you very much for joining us.